we are recording this session so that we can share it more broadly with the community. It's a beautiful, sunny Friday, midday noon. So those who can't be with us will be able to view the conversation at a time that is better for them. I'm appreciative of all of you who are here today and looking forward to this conversation about the work that our state Office of Health Insurance Commissioner is doing to ensure that insurers follow the regulations as outlined under both federal and state mental health parity laws. Just a little bit of housekeeping for folks. Those who are here with us today, feel free to use the chat function or the Q&A function to put out a question at any point during the conversation. You can also raise your hand and we can unmute you so you can pose that question. We've got about an hour and there's a lot of things to talk about, but it is complex. And so we encourage any of you to add in your questions or ask for clarity as need be. With us today is Commissioner Patrick Tigue. Welcome, Patrick, and thank you for being with us. Also with us today is Seamus Dirac, who is the staff attorney at the Rhode Island Parent Information Network. For anyone who isn't aware, RIPIN hosts a health insurance consumer helpline, which is a critical partner in ensuring that those of us who are facing barriers or struggling to get the coverage we need, or any problems at all that we are experiencing with our health insurance coverage, the RIPIN call center is an amazing resource and something we should all be proud of and all should take advantage of. We'll talk more about that later in the conversation. Also with us is Mark Gray, who's on staff at the Rhode Island Parent Information Network. He is the community engagement manager there, and he's going to be helping us today by monitoring the chat and Q&A functions so we don't miss any of your input or questions. With all of that said, I just want to give a little bit of an overview about the Mental Health Association of Rhode Island. The organization in our state has been around since 1916, more than 100 years, and has worked over that century to advocate for effective and compassionate community care for those with mental illness. Today, the Mental Health Association continues the effort fighting for equity in mental health coverage and effective statewide mental health and substance use disorder policies. So our executive director, Lori Marie Pashota, our board members, our supporters and community-based advocates are out there all the time talking to people like Commissioner Tigue and talking to our elected officials and members of our administration to improve our system, our statewide delivery system for mental health care and our state policies that impact that system. Back in 2018, the current executive director at that time, who I believe is on the call with us today, Ruth Fetter, really led the effort to develop the Parity Initiative because she recognized that this was really a civil rights issue and that we had important laws in place that a lot of people just weren't aware of. People weren't aware of their rights under mental health parity law, and that the Mental Health Association could do a lot to help improve that and in educating and raising public awareness. And that's really the first priority for the Parity Initiative, is to raise public awareness about parity, but also to help the effort to improve compliance with our mental health parity laws and to reduce the stigma that is often associated with mental illness and substance use disorder. So we do our work in a three-pronged way. We do events like this, public awareness and education events in order to inform and empower community with information they need. to assert their rights under mental health parity laws and via their health insurance coverage. We do research. We've facilitated focus groups, and we are in the midst of finalizing our report out on a pretty significant behavioral health provider survey. So we do research, and we work to assist in developing new or adapting existing law and policy that impacts people's parity rights. So we work in that three-pronged way. We have a stakeholder group, and our most important partner, I believe, is the Rhode Island Parent Information Network, and an important supporter of our efforts on mental health parity is certainly the Office of Health Insurance Commissioner. And so we appreciate OHIC's prioritization of parity within their scope of work. And with that, I really want to turn it over. This is going to be sort of conversational style, interview style with Commissioner Tigue and with Seamus. So my first question out there, Commissioner Tigue, for those who may not be aware, who are either watching this later or on with us live now, can you tell us a little bit about what the Office of Health Insurance Commissioner is?
Yep, sure, Karen. And I'll start by, before I dive right into that, just saying thank you to you and the Mental Health Association of Rhode Island for sponsoring this today and asking me to come on today and talk with you about this. As you said, behavioral health access and parity are among the office's absolutely highest priorities. And so for me, this is really important, and I really look forward to the conversation today. So just thank you for this opportunity. To speak more directly to the question you posed, I think I'll take a few minutes and kind of walk through OHIC as a whole, as you said, the Office of the Health Insurance Commissioner, where I serve as commissioner, and then talk a little bit about specifically our charge related to behavioral health, and then we can go from there. So again, for anyone who may not be familiar, the State of Rhode Island Office of the Health Insurance Commissioner, or OHIC, as we affectionately call it, because in healthcare we always like a good acronym. It was created back in 2004 by the State of Rhode Island General Assembly. And the office was charged at that time, and continues to be charged to this day, with essentially 4 statutory purposes, or 4 things that really comprise our mission. The first is, and where we always start, is that we're called upon to protect the interests of consumers of commercial health insurance. The second is that we are to encourage the fair treatment of healthcare providers by commercial health insurers. The third, and probably our broadest charge, is to improve the healthcare system as a whole, and specifically look at the system as a comprehensive entity and direct insurers toward policies and practices that advance access, affordability, and quality. And then finally, the fourth purpose that is also important as a baseline is that we have to guard the solvency of Rhode Island's commercial health insurers. What that means is we have to ensure that health insurers stay financially viable so that they can continue to provide and finance care for people in Rhode Island that actually need it. So really all of those taken together really comprise, from a mission standpoint, and the purpose of the office. And it's something, I and my colleagues at the office try to keep in mind in all the work that we do. We constantly try to come back to those statutory purposes of protecting consumers, ensuring fair treatment of providers, improving the healthcare system overall, and ensuring that health insurers remain solvent and financially viable. Through that, we have a number of important functions that OHIC carries out. There's a few that I would highlight here that I think, and several I think are specifically relevant to the conversation about behavioral health access and parity. So to really carry out our charge at OHIC as a policy reform and regulatory enforcement agency, some of the functions that we perform that I would note are first and foremost, and probably what you perhaps heard most about historically at the office, is that we're responsible for reviewing and either approving, rejecting, or modifying the actual premiums that are charged by health insurers. And so every year, health insurers that are offering coverage to individuals, to small employers, and to large employers actually file the rates they propose to charge. And the office reviews those, and then we make a decision ultimately about the rates that are going to be permitted to be offered by health insurers. Going right along with that, we also do what is called form review, which in parallel to that rate review process, we review a wide range of the coverage documents that insurers use with consumers or use to document the coverage that they are offering. And we ensure that those are in full compliance with state and federal law and that are as accessible as possible to consumers who rely upon those documents to know what's covered and the terms of that actual coverage. We also engage in what's called network plan certification. So essentially at the plan level, any health insurance product or plan, we review how those plans are designed and constructed to ensure, again, that they're compliant with appropriate state and federal law. We also have to certify any benefit determination or utilization review agents or agencies. So what that means in more common terms is if a health insurer relies upon any kind of outside entity to make determinations about the coverage that a member is entitled to receive, we certify that those entities are, again, are competent and are licensed properly in the state to be able to carry out that function. And then we also perform oversight to ensure that they're carrying out those functions, again, in the interest of consumers and in conformance with the law. The final three functions that I would note that I think are also important. One, Karen, you've already referred to, that we work very in close partnership with the Rhode Island Parent Information Network and Seamus and the team there, is consumer and provider complaint resolution. This is something we take incredibly seriously. It's a core part of our work to protect consumers. We think RIPEN's an incredible resource and we partner with them to carry out this function. But essentially, any complaint or really any challenge a consumer or a provider has with the health insurance system, including but not limited to behavioral health, they can file those complaints with OHIC or RIPEN, any channel. We try to have a no wrong door policy where consumers and providers can raise those issues if they're having challenges. And we work all the way from issue diagnosis all the way to resolving the issue. So that is a really important function for us in terms of complaint resolution. And then we also analyze those complaints to look for trends and seeing if there's issues that we need to address at a higher level from a regulatory enforcement standpoint. So that gives rise to the next function I wanted to mention that we'll talk a lot more about later in the conversation, I know, is related to market conduct examination. So I'll talk more about those later on, but essentially these are exams or investigations where we suspect there are systemic issues with the way that commercial health insurers are carrying out their business practices and administering benefits and making payments for benefits here in the state. And we ensure that we investigate insurers fully to ensure that they are following all applicable laws and regulations as well. And then obviously, if we find that there's any issues and they have not done so, we can impose penalties and corrective action and ensure that those issues are resolved on a go-forward basis. And then finally, the last function I would point to is OHIC issues a large volume of what we call regulatory or sub-regulatory guidance. So this is either formal regulations that speak to how OHIC interprets the law and the rules that insurers need to follow to be compliant with Rhode Island law related to commercial health insurance, or we issue guidance documents that direct insurers toward policies that are going to improve the system and further the broad health reform efforts that we are focused on. So really overall, that really is overall how the office sort of grounds its work and the major functions that the office carries out. But again, we also have some specific charges related to behavioral health, and those really fall into three categories in terms of our powers and duties. One is essentially behavioral health parity. So again, ensuring that coverage is provided for behavioral health, both mental health and substance use disorder coverage, essentially to the same extent and in the same way that other forms of healthcare like physical health are covered and provided by commercial health insurers. The second is about access, so really working to develop a full continuum of care so that behavioral health services across the full continuum are available to consumers, and again, directing insurers toward policies that will help advance that. And then finally, the third behavioral health charge that we have related to, so the first is access, the second is parity, and then we also have an obligation to really direct insurers toward policies that focus on integration. So to the extent possible, ensuring that mental health and substance use disorder services are delivered in an integrated way, in a combined way, or in certainly a streamlined and coordinated way with physical health care services, so that the whole health of an individual can be addressed in the most convenient and accessible setting. So I will stop there. I've said quite a lot, but that's really the overall framework for OHIC as a whole and behavioral health in our overall work.
Terrific. Yeah, it's a lot. One of the things that I might add that OHIC has done, at least in the past several years, is some important convening work of various work groups. So, the OHIC facilitated work group on telemedicine being an important access issue in behavioral health. The market stability work group a couple of years ago that really helped build, at least if not consensus, some understanding across different entities, different stakeholders on the issue around what our insurance market, commercial marketplace might look like and how we might seek to shore that up. So those are that's an important part. And I guess I would emphasize as a part of this conversation, and maybe you can allude to this, it's a little bit off topic, but there are multiple opportunities for Rhode Islanders to engage. So you mentioned the Ripon call center. We need people to alert your office or Ripon, via Ripon, to issues that they are experiencing with their insurer. But there's also other opportunities like the Health Insurance Advisory Council, maybe a moment about that group and your work to facilitate that group and the role of that group.
Sure. No, Karen, thanks for that specific question. So yeah, to quick first revisit as you said, the issue of complaints. I want to just really emphasize, one, what a great resource in particular Ripon is, as well as our office is, for helping individual consumers get their issues resolved, as well as providers. So that is something, again, we make sure that we resource that adequately, and then we really take that responsibility seriously. So that has value not only for having an individual resolve their issues, which is our first and foremost our priority, but I think you alluded to as well, and I mentioned it earlier too, it's also really important from a systemic and an oversight standpoint, because it helps us. Oftentimes consumers raising issues with direct experiences they've had and direct challenges that they've had, that oftentimes will alert us to issues that could be systemic, or that many other consumers who haven't been able to or don't know that they can speak up and raise those issues, and we can go and investigate those issues and see if they can be addressed on a system-wide basis, either for a number of commercial health insurers or for an individual one where maybe a particular issue is consistently rising up. So really couldn't agree with you more, and would really encourage individuals to contact the office, contact Ripon, help us understand what issues we need to help you resolve, but also help make us aware of the consistent issues that you are actually seeing so that we can take action. And again, I'm also very, very open to, we're always trying to think about how we can publicize that more and make people more aware of that. So or how we can make those services more accessible. So if individuals have feedback about that, or ways that we can improve our processes or improve awareness about that, we are very open to thinking about creative, innovative ways of actually doing that, because it is such an important function for us, both from solving individual issues and identifying systemic ones. You also mentioned the Health Insurance Advisory Council. So this is a statutorily required advisory group that advises me as the Health Insurance Commissioner and advises the office as a whole. We have usually about 10 meetings a year, basically on a monthly basis, largely, where we have a group. It's a public meeting, to be clear, anyone can attend. We have opportunity for public comment, and we'd encourage as many people to attend as they are able to and find helpful. But the council represents a diverse array of different individuals who represent a range of constituencies, including consumers, employers, providers, and others and consumer advocates, for instance, who all have an interest in supporting and advising OHIC as we carry out our policy reform and regulatory enforcement responsibilities. And so the office, we try to bring to that group important initiatives that we're carrying out, and so that we're informing and educating about the work that we're doing in the office, but also have it be a bi-directional conversation where we're hearing and listening about the concerns of those individuals. And so would really encourage folks to attend that. And during our public comment period, every single month, we're really open to hearing comment and then thinking through how we can address issues that arise in that forum. So absolutely agree, Karen. That's another really important and opportune way to engage with the office.
Yeah, and I think it's important that Rhode Islanders understand, for better or for worse, wherever people fall on the debate about what our overall healthcare system should be, the office is given that collectively so far our decision is to have a market-based system that provides you that card, which is your access to healthcare, that it's important that people participate and engage, especially if they are experiencing what they believe to be a challenge. And so the fact that we have an Office of Health Insurance Commissioner and the fact that there are these avenues is important for people to participate in.
Yeah, Karen, can I jump in really quick on that? Because I really appreciate you bringing that particular topic up. I just want to really underscore what you said, which is that, again, to your point, for better or for worse, as you said, we have right now, and again, for a long time previous to this, right? We have a market-based private insurance system, and so OHIC's role in that, right, is to ensure that system works as well as possible for consumers at its final place. So that's our role. Our role is to be, and that's why I always talk about our function in terms of being both policy reform. How can we change that system to make it work better? And then regulatory enforcement. How can we enforce the existing rules around the system to make sure, again, that they serve consumers as well as possible? And so that really is a role. I think that's the right way to think about it. That shouldn't preclude anyone from advocating for changes to the system that they think are important. But our role is to make the existing system work as well as possible and to make incremental advancements to it that will ultimately serve others well. So just thank you for underscoring that I think the broader policy reform conversation and making the current system work better, I really think those things are complementary. They're not mutually exclusive. And OHIC has a role to play in that and play partially in both of those things. But I think having people's engagement with both of those conversations, I think will really help us have the system that we all believe that we actually need to serve people as well as possible.
Yeah. So I want to segue to talking more specifically about mental health parity. You had brought up the issue of market conduct exams. And so this is important. So could you tell us a little bit, just briefly, about what a market conduct exam is, and as relates to the behavioral health market conduct exams or the exams you conducted around parity, can you tell us about the results?
Sure. So again, what market conduct exams are, essentially, I think the easiest way to think about them is they are investigations. And what they are they're investigations that OHIC takes into the business practices of any commercial health insurers that fall under the jurisdiction of the office. So in Rhode Island, to be concrete, largely the four that you would normally think of there are Blue Cross Blue Shield of Rhode Island, United Healthcare of New England, Neighborhood Health Plan of Rhode Island, and Harvard Pilgrim Healthcare and Tufts Health Plan, who have currently merged into, historically, they've been operating here in the state as Tufts Health Plan. But really, those four insurers, at any point, the office can launch a market conduct exam into either one of those insurers or multiple ones or all of them to assess whether or not they are engaging in conduct that violates law and regulations. And so to your point, the office back in 2015 initiated a market conduct exam into all four insurers and specifically focused on behavioral health. And so the goal of that exam at the time, and it took a multi-year period. I will note that market conduct exams, because they are investigations and require, a very involved process and a really important process of gathering evidence, reviewing that evidence, having the entities being investigated have the opportunity to respond to the preliminary conclusions that the office draws from that, and then to negotiate a settlement around what corrective actions the entity will take as a result of any findings the office has from that exam. They do typically take a significant amount of time. The behavioral health exam, because it was so important and so complex, again, took in most cases about 3 or 4 years. That is longer than is typical. I would say the average exam takes more about 12 to 18 months. But in the case of this particular exam that was launched around behavioral health in 2015, and was concluded between 2018 and 2020, depending on the particular health insurer that we're referring to. What it did was measure compliance with federal and state laws and regulations relating to coverage of behavioral health benefits. And so particularly, we looked at utilization review, which involved a sampling of over 1,000 case files that were selected for behavioral health and prescription drugs related to behavioral health treatment. We looked at how insurers were approving, denying, or handling appeals related to those case files. We also looked at how and to what extent they were consulting with independent behavioral health clinicians to determine whether or not the decisions that they were making about rendering services and approving types of utilizations were clinically appropriate. So that was really the core of what the exam was focused on. And so I think the national, go ahead, please.
Yeah, just to clarify, you took individual claims that had been filed and looked at those to see how the insurer had handled that claim, and if they had handled it fairly and according to laws.
Yes, that's exactly right.
And you looked at a lot of them, right? Hundreds, I think.
Yeah, actually, I think close to 1,000. Yeah, as a sample across. And again, and we extrapolated from how we assessed them to have adjudicated or made essentially we looked at the decisions and the processes they used to make decisions around those claims, and we determined whether or not that was appropriate and fair from a legal compliance standpoint. Exactly. And so the next question, of course, naturally, is what did we find? And so what we found is that there were multiple areas of non-compliance. Again, there was some variation by commercial health insurer, but I think the general things that we saw that were common areas of non-compliance were in several areas. The first was the consistent use and application of clinically appropriate utilization review criteria. And so what that means, right? So if you think of when a health insurer has to make a decision about rendering coverage or paying for services, would be another way of saying it. There's both what criteria do they use to make those judgments, and then how do they actually use that? And so we actually looked at both those aspects. What criteria are they using, and are they applying that criteria, even if it's the right criteria, consistently and appropriately? And for both behavioral health services and related prescription drugs, we found that there were multiple issues around both those pieces about, in some cases, not using the appropriate clinical criteria and or not applying that criteria in a consistent way across different similar cases. So that was one very significant finding. Second,
so what that meant, just to clarify in lay terms.
Sure.
What that meant was that you discovered that individual insurers, in making a decision, let's say it had been my claim, and I had gotten a letter saying, we're not going to cover this medication, you have to take this one instead, or we're only going to approve you to see a counselor 1 time a month instead of 2 times a month. Those kinds of decisions is what you mean by sort of utilization review, and they were making those decisions based on sort of a checklist of their own to determine, so for Karen, this is what we think her problem is, and this is what we think should be sufficient for her treatment or services.
Right. That's really well said, Karen. Yeah, exactly. we found instances where, again, where coverage was denied, where either the reason the insurer decided to deny coverage was that they were using what we consider to be clinically inappropriate criteria, meaning it wasn't the right standard to judge it on, or that they had the right standards, but they weren't applying them fairly or consistently. And so it resulted ultimately, to your point, in denials for services that should not have been denied. That's exactly right, for you as an individual consumer. So any of us who have gotten a benefit letter where we've had a service or a portion of a service denied, that was exactly the kind of scenario for behavioral health that we were looking at on a case-by-case basis. And then again, based on our sample, because we couldn't review every single claim for that time period, we were generalizing from that and saying, we think this shows evidence of this given commercial health insurer's practice that is systemic or that is a problem across the board. And therefore, we're going to require you to take action to address that. So that was one major area, and was really in some ways the core of the exam. The other piece that I really focus on, and there's many kind of sub findings underneath this, but our utilization review practices that we specifically cited that could have resulted in impeding care to consumers. And so what are some examples of those? Separate and apart from clinical criteria, there were additional practices that we found in some cases were being engaged that could have resulted and did result potentially in care being denied or being impeded that was detrimental, and therefore we thought violated the law. So one example of that is where the commercial health insurer made a particular clinical judgment with the clinicians that it employs that didn't take into adequate account the treating provider's clinical judgment. So again, you're seeing a given behavioral health provider who recommends a certain course of treatment for an issue that you're experiencing. The commercial health insurer makes an alternative judgment about that and says, no, we disagree with that treatment being proposed. And what we looked at to examine was, did the insurer weight the treating provider judgment sufficiently, or take into account that? And we found, again, in cases they did not do that, so that then treatment wasn't provided or was delayed in being provided that from a clinical perspective we argued should have been. So that's really one example of that. Another is that when you think about care transitions from one provider to another, if a member changes providers or has to move to another provider for a different reason, we found that commercial health insurance in many cases did not do enough to ensure that the patient or the consumer's safety and welfare was taken into account during that actual transitional period. And so one way of doing that is through things like continuity of care. So ensuring that, let's say, even if a provider moves out of network, meaning a provider is no longer contracting with that insurer, does the insurer allow sufficient time for the member to transition to a new provider before it stops paying for coverage? So those were other areas that we found to be problematic on the part of the insurers.
So that's a little bit about the results, which is alarming. I mean, we weren't surprised at the Mental Health Association because we've been hearing these kinds of things from patients. We were anxious for the results of the exams because we thought it was important that people understand these were systemic. In response, there have been some changes in behavior on the part of insurers. Can you tell us a little bit about how have those exams actually changed the system in ways that patients can now begin to maybe even feel the impact of?
Sure.
I know that Blue Cross Blue Shield was among the first. They dropped prior authorization reviews.
Right. Yeah, so we should talk about that because I think it's really important. I think it's again the natural next question. So, and one thing I'll note just for anyone who has an interest, on the OHIP website, the final examination reports for each insurer are available, And those are quite voluminous, but what's I think particularly insightful to look at in those, there's an itemized list of the findings or of the violations in those. And so you can see by insurer what the specific issues we found. So that's something that are particularly interested in. I will note too that I know, and I've heard there's a really significant interest in this, and we'll be putting this out later this month, even though the exams were completed now some time ago. Each insurer was required to submit a plan of correction, which again documents for each finding for that specific insurer what the issue was, what action it took to address that issue, and what the implementation date of that change specifically was. Again, to a significant level of detail. So what we've asked each insurer to produce is a summary table for all that information that can be an easily accessible document. And so we will have those available. I'm looking for next month. And so we'll be happy to provide those for anyone who wants to go deeper in terms of what each individual insurer it has done at a very granular level. But to answer your global question, Karen, that I think is really important, what you cited in terms of how did it change insurer behavior, I think the Blue Cross example is far and away the most significant one and the most important because of the role Blue Cross plays in the state in terms of being by far our largest commercial health insurer here in terms of the people that it serves and covers. So Blue Cross made the decision as a result of these findings at OHIC's direction. They chose to address a number of these things by simply removing all utilization review from in-network behavioral health services. So that is a very concrete, far-reaching change that remains in place today. In addition to that, across the different commercial health insurers, including Blue Cross, there was a behavioral health fund created at the Rhode Island Foundation where they were that again was specifically created to support strategies and service models that enhance prevention and affordable behavioral health care services. And so the insurers have contributed approximately $8.3 million to that fund to date. Why that's important is not just as a penalty, but because it's actually a required investment of the insurers that then can be invested by the Rhode Island Foundation in things that can proactively advance additional behavioral health access. So I think that's very, very important. I think third, the only other thing that I would cite here in terms of changing insurer behavior on a global scale, insurers are required now on an ongoing basis to conduct their own internal auditing of their utilization review practices, and they have to report that to OHIC quarterly, at least through June of 2022. And OHIC will review the results of their audit, and then we also reserve the right to re-audit them or conduct additional exams to ensure that they are following through with any corrective actions in this area related to utilization review. So again, I wouldn't represent the results of the exam as all the work that needs to be done, or that there isn't more work that needs to be done in this area. There absolutely is, and it's work OHIC absolutely is committed to continuing. But I do think that it did produce a very tangible result in terms of changing insurer practices and holding them accountable for practices in the past that simply were not acceptable.
Thank you. We're looking forward to seeing those, the summary of the corrective plans, because I think that's an important role that we can help play through the Parity Initiative and our partnership with RIPEN to make sure patients of behavioral healthcare services know you should be seeing this difference. So thank you for that. We're looking forward to it. We are at just a time check. So we are at 12:40. I want to make sure that Seamus has a chance to talk a bit about the call center, how people can access and use it, and what are some of the most common parity violations that people experience. And then we can come back to talking about some of the current issues like network adequacy and that kind of thing. So Seamus, I want to turn it over to you to share some information from your perspective.
Sure, absolutely. Thanks, Karen. And thank you very much to Commissioner Tigue for participating in this conversation today, and especially for OHIC's ongoing commitment to resolving a lot of these behavioral health concerns that consumers have had. I do want to point out that when OHIC started the market conduct exam process back in 2015. We were one of the first, if not the first state to do behavioral health specific market conduct exams, I believe. And it's really been a template that many other states have taken. This is obviously not a Rhode Island specific issue. Behavioral health access is problematic across the country. But we're very fortunate here in Rhode Island to have an Office of the Health Insurance Commissioner that has made this a top priority and has advanced this. So thanks again to OHIC for that. A little bit about the RIPEN, the Rhode Island Parent Information Network, and our call center. We are a community-based nonprofit. We're 30 years old this year, actually. And we started working with families of kids with special needs in advancing access to educational and health support. We've since grown from that to serve all Rhode Islanders across a wide variety of both health and education related concerns, though we do keep very strongly our commitment to supporting individuals with special needs, including behavioral health needs, and that's reflected in some of the work that our call center does. We operate a Rhode Island-based call center for all Rhode Islanders with any sort of health insurance, whether that's fully insured commercial plans that fall within OHIC's jurisdiction, largely smaller employers and individual market plans. But we support individuals with plans through larger employers. We support individuals with Medicaid, Medicare, any form of health insurance that's related to Rhode Island, we're happy to assist with. And in that work, we do a lot of assistance with helping people access health insurance more broadly, but we also, including enrollment in health insurance, so people can actually access those services they need. We also help with individuals who have been denied access to a specific health care service, including behavioral health services, obviously, and we see a lot of issues around that with people coming in that have a need for a health insurance service, but have been denied it through their health insurance carrier. So with that work, we work very closely with the Office of the Health Insurance Commissioner, both to resolve individual issues, but also to flag broader trends that we're seeing. Some of those behavioral health issues that we see that may be parity violations include the medical necessity review that Commissioner Tigue has talked about that was looked at in these market conduct exams. Frequently, the difficulty is with the delegates that Commissioner Tigue mentioned earlier as well, that OHIC has oversight over, where the plan itself may not be doing the utilization review, might not be doing the determination as to whether a service is medically necessary, but instead delegates it to another party. Sometimes dealing with those parties can be difficult, both for consumers and for providers. So we'll assist with that, but we'll also flag issues that we see there. Another thing that I want to flag that is something that we think is important in ongoing action, both statewide through legislative action, but also specifically through some of OHIC's work, revolves around provider network accessibility. There's a big issue in the behavioral health world where provider networks for behavioral health providers are almost always smaller than their medical, surgical, general health counterparts. And part of the reason for that is the under reimbursement of behavioral health providers. That's something that we see across the board in behavioral health, but also specifically in some specialties, including child psychology. And because of lower reimbursement rates for behavioral health providers, it's much more difficult for consumers to access an in-network provider and frequently have to go out of network, pay completely out of pocket, and not have health insurance coverage essentially for their behavioral health services. So that's something that we think is very important, that continue to be addressed, and that is a major gap in our network adequacy currently. And then a little bit about what individuals can do to resolve these issues when they see them happening to themselves, either as an individual or as a provider working with clients that are having these issues, is that a lot of people see a denial from their insurance company and think that's the end of the road. That's not the case. It's important that people know that just about any health insurer decision can be appealed. And the way that that process generally works is that any denial has to be based in some sort of grounding. As Commissioner Tigue had spoken earlier, there are clinical necessity criteria that insurers will use. Those criteria have to be accessible. They have to be applied equally across the board. They can't be applied arbitrarily or differently, and they have to be applied to their terms. They can't just have a set of criteria, but apply a different set of criteria. Those were all things that were part of OHIG's market conduct exams, and that's important that we continue to look at today. And so when a denial does issue, it's important that consumers look at that, see what the rationale is, speak with their providers about that, and most importantly, don't hesitate to reach out to Ripen about that. That's exactly what our call center is here for. We're always more than happy to work with individuals who have been denied access to coverage and who need assistance with that appeals process. It's quite complicated sometimes. It's sometimes very overwhelming for individuals, but you don't have to go through that process alone. You have the assistance of the Ripen call center, and we work very closely with OHIG to resolve these sorts of issues and to flag trends in these issues that we see. I know Mark had posted in the chat our phone number. I'll say it again for everyone. It's 401-270-0101. You can also find us online at www.ripen.org. You can also email any sort of complaints to callcenter@ripen.org. We try to make it as accessible as possible for individuals to send complaints our way. And then we'll work on those. We'll flag anything to the Office of the Health Insurance Commissioner that requires that sort of escalation.
And I would add, I know you said it, but I'm going to emphasize that the call center is bilingual, which is very important. And I would also add that we have a number of community health workers and others who are dropping in on some of these conversations and webinars. Seamus and I have participated in some workshops and trainings with them. This is an important support too for those who are working in the field and coming up against situations where they've got clients or community members or members of their faith community, their school community, who are in crisis. Particularly, I think this is a challenge for those who are struggling with a substance use disorder and may be in a moment of time where they're willing to access some supports and help, right? And if they come up against the wall or a barrier from their insurer, in that moment or in the midst of that moment. This is a place where family, community health workers, friends can really help have quicker action by utilizing the call center to partner with them in helping that person. And so I think it's not just if you yourself are just got a letter of denial or have just been told by your provider that, oh, I can only see you, once a week because your insurance won't cover more than that. It isn't only in those moments. Those are important moments too, but it's in those moments when someone is in crisis and you need quicker action than you might be able to manage on your own. Call on the call center for their help. So I can't emphasize that enough. And we've heard from people that we have referred to the call center, how helpful it was and has been to them. So we're glad we have that. We're one of only a few states in the nation that does. So we should utilize it as best we can to make sure people are overcoming barriers to accessing care.
Thank you for that.
Yeah, so Seamus alluded to issues of network adequacy and reimbursement to providers as a part of that. And network adequacy is, in fact, a parity issue. Insurers are required to have an adequate network of providers so that people can access necessary services and treatment in a reasonable time frame and within a reasonable distance of home. What we know is that those advertised networks that insurers list on their websites, you can call through that list And I just got an email yesterday from somebody seeking some help on this. You can call dozens of names on that list and find out there's a 3-month or a 2-month waiting list to see somebody, or that the particular service you need, outpatient particularly, just isn't something that they're offering right now because they're only providing in-hospital services or whatever the case may be. And we understand part of one of the important factors in the limited networks of providers that we have in state and nationally is because behavioral health providers are systemically under reimbursed, not only by insurers, but overall through our government funding mechanisms and otherwise. So Seamus, do you want to talk to us a little bit about some of the policy work that is going on right now to try and fix that?
Sure. I can speak a little bit to that, and then I want to make sure that the Commissioner Tigue also can weigh in a little bit. So as you said, a significant issue across behavioral health, and as I mentioned earlier, is the adequacy of provider networks. That's something that is clearly defined within the federal parity law as falling within parity, is specifically the adequacy provider networks due to reimbursement rates paid. But it's a difficult lift, and it's not something that it is not potentially subject to as easy as a resolution as a utilization review denial. If you're issued a medical necessity denial, you can appeal it, and if it's seen as incorrect, that can be overturned. You as an individual cannot change the reimbursement rate that is being paid to a provider. These sorts of issues do require a much broader resolution. And they frequently require a resolution across not just one subset of insurers. It can't solely be resolved at any individual level. It's something that requires a broad approach. But one thing that is being advanced is based on studies that have been done that show the systematic under reimbursement of providers. There is a bill in the legislature this year to advance an increase to reimbursement rates for behavioral health providers to hopefully bring more providers into those networks, such that when you're looking for an in-network provider, when you can't afford to go out of network, but you need treatment right away, by bringing those reimbursement rates up, the hope is that more providers will filter into those networks, will agree to accept those reimbursement rates, and then will be available when individuals do need to see a provider right away.
So that's some pending bills before the General Assembly. But Commissioner Tigue, talk to us a little bit, because you have some role that you can take on and play in this issue too.
Yeah, absolutely. Thanks, Karen. Thanks, Seamus, for thinking about this holistically. So I think to your point, Karen. So what we're exploring at the office, and this month we're going to start having a broader public dialogue about this. That I think is really a complementary effort to the type of legislative action Seamus was describing. So what we are looking at the office is among what we're calling our next generation affordability standards. And just really briefly, affordability standards are requirements the office currently has that are, again, requirements of commercial health insurers to take certain actions that enhance, again, the affordability of health insurance coverage offered, but also improve quality. And so what we're thinking about for our next iteration or next generation of these, one of those that we are exploring is a standard or a requirement related to behavioral health spending to address exactly the kind of issue Seamus was referring to earlier. So the idea here that we're going to, again, be vetting and discussing publicly, and then ultimately moving forward with a regulatory process to enact is to essentially evaluate in a really rigorous evidence-based way, and even a more granular level than the type of analysis that's been well documented, as Seamus said, about the systematic under reimbursement of certain areas of behavioral health spending and provider types. We're going to do an in-depth analysis of that. Then based on that analysis of looking at where there has been, or rather where the systematic underinvestment has been most problematic and has produced the most access and quality problems, and looking at if we increase spending, where do we have strong evidence that that's going to improve the experience and the outcomes for consumers. and as well as looking at benchmarking our spending against other states, so we can see specifically where Rhode Island is a negative outlier. Where have we underinvested as a state that could really improve consumer outcomes in behavioral health? Where can we invest where other states have and we have not? So taking all that into account, ultimately we envision structuring a requirement that insurers shift spending into those areas to incrementally address the type of systematic under reimbursement that Seamus was referring to earlier. And again, we believe that we have existing authority to do this under existing law and regulation. And again, we think this will be a really meaningful incremental step to drive spending toward areas of behavioral health and behavioral health provider types, so the consumers can see greater access and improved outcomes in this area. But again, it's meant to be a complementary strategy, and one that I wouldn't want it to be viewed as something that means that legislative action might not otherwise be necessary. I think these things can work in tandem and should work in tandem.
Yeah, the multi-pronged approach to fix what is really a critical issue. And we all know we are currently facing a pretty significant crisis coming out of the pandemic in behavioral health care. And yet our system is under-resourced and not prepared for coping with it. And we've seen what that means with the opioid epidemic. And so it's important that we all participate in pushing solutions that make sense for people, and that people's experience and people's capacity for achieving or maintaining emotional well-being is first and foremost. And so we appreciate that we've got partners on that front with the Office of Health Insurance Commissioner and our mental health parity stakeholder group and others, champions in the legislature like Senator Miller and Representative Tansey and Craven and others. So we are quickly approaching the end, and I want to make sure that for those who are online with us, that you have an opportunity to pose a question or to speak up. So if there are, please, now's the time. We're going to have to wrap up soon because we scheduled this for an hour. But if you are viewing this after the fact, if you're viewing it not live, do not hesitate to forward a question or a comment. You can email me directly at riparity at mahari.org, or you can go through the Mental Health Parity website, which is www.riparity.org. Again, the Rhode Island Parent Information Call Center phone number is 401-270-0101. And the Office of Health Insurance Commissioner website is, I believe it's ohic.gov.
Yep, www.ohic.ri.gov.
Thank you. So I'm not seeing any questions. I see a thank you from Ruth Fetter. Mark, anything you monitor that you want to throw out to us? Otherwise, we are at 12:59 p.m.
I think we're good. Yes, thank you all very much.
So, Commissioner, again, thank you for joining us today. Thank you, Seamus. For those who registered and who participated today, we will have a recording of this that we will share with everybody. It will be posted to YouTube and Facebook and to the website. And we will be sending out that link along with some other materials and website links that we talked about here today. So greatly appreciated, and I hope everybody has a terrific weekend and gets to enjoy some of the sun this afternoon and tomorrow.
Thank you, Karen, so much. Thanks, Seamus. Thanks, Mark.
Thanks, Karen.
Thank
Thanks.
you.